We'll start with a case. We have Miss B. Nancy P., who is a 60-year-old female with a history of hypertension, obesity, paroxysmal atrial fibrillation, COPD, and HFpEF, who presents to the ED with a subacute dyspnea on exertion for the last few weeks. Vitals are notable for a heart rate of 100, BP 160/90, respiratory rate 24. Exam is notable for a bed weight that is 10 pounds above baseline. She has some scattered wheezing throughout the lung fields and 2+ lower extremity edema of unclear chronicity. Her JVP is difficult to assess, and her labs are notable for a high sensitive troponin 7 to 5, which is negative or downtrending, and a BNP of 76. This is a common scenario that we often see here at the VA. So the admitting team is unsure about whether the patient has acute decompensated heart failure or a COPD exacerbation, and decides to treat for both with prednisolone, which is a new drug I have invented, combo Lasix and furosemide. Prednisone. The question then is, does the BNP less than 100 picograms per milliliter rule out acute heart failure in this patient? So our answers are yes, no, or it's complicated. And I will make the argument today that the answer is definitively no, depending on the question we're asking and why that is the case. So what is B-type natriuretic peptide, or BNP? It is a peptide hormone which is secreted in response to ventricular wall stretch. Similarly to ANP, which is atrial wall stretch. And what does BNP do? BNP binds to natriuretic peptide receptors, the NPRs, which increases cyclic GMP and does all sorts of wonderful things that we actually want in heart failure, including increasing natriuresis and therefore diuresis, as well as decreasing sympathetic activity and decreasing RAS activation. There are a number of mechanisms by which BNP is cleared from the circulation, which we'll elaborate in a bit. And BNP levels were discovered in the 80s and put into clinical use in the 90s. And they are useful because they correlate with the severity of heart failure symptoms and also with worsening renal function, as we can see from this graph here. So that begs the question, we use this as an adjunct. Remember that heart failure is a clinical diagnosis, as is everything, but we often use the sum total of labs and exam findings to help with that, and BNP can be a helpful marker. The question is, when is BNP not reliable? In addition to heart failure, BNP levels may elevate with older age, CKD due to decreased clearance of BNP from the circulation, atrial fibrillation, which can increase ventricular stretch over time, especially if it's chronic, pulmonary embolism, and then most notably with neprilysin inhibitors, of which we use Entresto here at the VA. Similarly, I think it's important to note, and this is what I really wanted to focus on, BNP levels may be lower than expected. Sometimes people say that it is falsely lower, which I think is not accurate in terms of semantics. With obesity, especially if the BMI is greater than 35, and then in acute events like flash pulmonary edema and acute pulmonary embolism. It takes time for that peptide to be synthesized due to transcription. And so if you have an acute submassive PE, the BNP actually may not be elevated. So the cutoff for BNP actually come from one large study called the Breathing Not Properly trial, the BNP trial, that helped to establish the cutoff of 100 picograms per milliliter, which yielded a sensitivity of 90% for the diagnosis of heart failure. And you can see the ROC curve here on the left. And they noted, though, that a lower cutoff of 50 was actually better for ruling out heart failure with a negative predictive value of 96%. So if it's less than 100, that's good, but if it's less than 50, that's even better for ruling out. And I've highlighted those values there for you. What we should talk about, though, is obesity, which correlates with lower plasma levels of BNP in patients with both non-heart failure and heart failure. And we can see here that to get a 90% sensitivity for diagnosing heart failure, that was actually achieved at 54 for folks that had a BMI greater than or equal to 35. And that the sensitivity and specificity of a BNP cut point of 100 was actually only 77% specific for that group. So you may actually be missing a fair amount of heart failure by thinking that because the BNP is less than 100, but greater than 50, that they do not have heart failure. And so why does obesity lower BNP levels? Obesity both increases clearance of BNP through the increased expression of NPRC, increasing GFR filtration, and there are higher levels of neprilysin in adipose tissue. Obesity also suppresses BNP gene expression through increased androgens, which is a really important mechanism that is currently being explored. And that is all I have. This is the summary slide. So what is BNP and what does it do? It is a peptide made in response to ventricular wall stretch, which increases natriuresis, decreases RAS and sympathetic tone. BNP is affected by obesity, which can result in lower than expected values due to both decreased synthesis and increased clearance. And when using a BNP cutoff, 100 is 90% sensitive for diagnosis of heart failure if the BMI is less than 35, but we should use a cutoff of 50 for 90% sensitivity for a diagnosis of heart failure in those with a BMI greater than or equal to 35. And that is all I've got. What questions?